Hello and welcome. My name is Csaba Dégi. I am the principal investigator of the CANPRIM project. This is the cancer distress follow-up study among outpatients in Romania, beyond oncology into primary care. The CANPRIM research project is the first nationwide study to build the evidence focused on the psychosocial burdens on distress and on pathways among cancer outpatients in primary care settings in Romania. To find out more on our research project, please visit our website, that is canprim.psychooncology.ro. Now, together with my fellow colleagues, Kállay and Flavia Medrea, we are inviting you to join our presentation. Thank you. We are from the Babeș-Bolyai University from Cluj, Romania, and today we are talking about the correlates of fear of cancer progression during COVID-19 in Romania. Let me start by saying a few words on the psycho-oncology care situation in Romania, especially during COVID-19. According to the International Agency for Research on Cancer, Romania was among the top EU countries with the highest mortality rate with regard to the most types of cancer, the highest for cervical cancer. So, in 2020, in Romania, 98,886 new cases of cancer were diagnosed and 54,486 cases were reported with the main cause of death, cancer. This is an enormous burden for our society, but also the fact that psychosocial care is not yet a common practice in oncology. It's really an important vulnerability. The Romanian healthcare system, especially the public healthcare system, has real difficulties in offering quality psychosocial care for people affected by cancer. We have to say that the medical and healthcare staff acknowledges psycho-oncology needs, including cancer distress felt by cancer patients. However, psychosocial care activities, resources, and possibilities are underfunded, non-existent, or understated, or considered neutral in the patient's pathway or in the healthcare setting. And actually, a vast majority do not use tools or standardized psychosocial measures or protocols for cancer distress screening and management. We know from previous research that having a periodic follow-up has been associated with lower levels of fear of cancer recurrence because of the personal control involved or emerging as a periodic follow-up is considered. But unfortunately, the COVID-19 pandemic imposed restrictions and there was a limited access to regular checkups and medical services in oncology all over EU and also in Romania. Fear of cancer progression or fear of cancer recurrence is defined as fear, worry, or concern relating to the possibility that cancer will come back or it will progress. Fear of cancer, FCR, and fear of progression, FCP, are not anxiety. They have a correlation and an association with generalized anxiety, and they are certainly anxiety symptoms, but we shouldn't confront the two experiences of cancer patients. FCR and FCP are cancer patients' greatest concerns, and actually FCP is one of the most reported unmet need in oncology patients, between 22% up to 99% of patients reporting it. FCR and FCP are significantly higher in unmarried, widowed, or childless patients. Also, we know that FCR and FCP are negatively associated with income and education level, with physical and mental health, and also with social support. And there is a positive association with pain, anxiety, depression, and negative social interactions. Research has shown that during COVID-19, FCR was negatively correlated with communication satisfaction, perceived risk, impaired sleep quality and quality of life, and also elevated levels of anxiety and depression. Gender differences were clearly identified in this context, women being more likely to report a higher FCP, and also fear and anxiety associated with cancer. As we have heard, fear of cancer progression and fear of cancer recurrence negatively impacts cancer patients' quality of life. On the side of longitudinal studies, we know that the greater FCR predicted lower physical, emotional, and functional well-being, and was also negatively correlated with health-related quality of life. On the side of cross-sectional studies, we see a strong negative correlation between FCR and quality of life dimensions and emotional functioning. FCP is negatively correlated with all 4 dimensions of quality of life: physical, social, emotional, and functional well-being. Also, emotional well-being is negatively associated with worry about breast cancer recurrence, including spiritual well-being that has been shown to be negatively associated with fear of cancer recurrence. Now let me introduce a concept which is called illness intrusiveness, first presented by Devins in 1996 in connection with chronic life-threatening diseases. Illness intrusiveness is actually an illness-induced disruption to lifestyle activities and interests that, can compromise psychosocial well-being and contribute to emotional distress in chronic disease, according to the original definition. Recently, it's an emerging area of research in the psychosocial domain, and, studies are assessing the extent to which a cancer diagnosis is disrupting important life domains and the way it interferes with patients' abilities to engage in those valued activities. Illness intrusiveness is positively associated with reduced subjective well-being and emotional distress. Subjective well-being is affected. Cancer patients reporting ongoing challenges in work-related domain or job-related domain, in social life, family, and other relationships, including the sexual life. In an 8-month-long longitudinal study, women who were married or partnered were less likely to report low illness intrusiveness for intimacy domain, and also participants reporting elevated illness intrusiveness in at least one of the domains were more likely to have anxiety disorders. So these are the background and the factors that we have taken into account in our study. Let me share a few words about our study design. The objective of our study, the CANPRIM, was to investigate correlates of fear of cancer progression in cancer outpatients during COVID-19 in Romania. Participants were 330 Romanian cancer outpatients, assessed during 2020 and 2021, the most active period of the pandemics. As we have just mentioned in the introduction, we have used 2 important instruments which were for the first time included in an oncology research in Romania. Fear of Cancer Progression Questionnaire, FOPQ. This is a validated self-report instrument that measures on a 5 points Likert scale the fear that an illness will progress, and it uses also 5 subscales: affective reactions, partnership and family, occupation, loss of autonomy, and coping with anxiety. The second instrument that we have used is the Illness Intrusiveness Rating Scale, which is also a validated self-report instrument that measures on a 7 points Likert scale the illness-induced interference with 3 life areas which are central to the quality of life. This is the instrumental, intimacy, relationships, and personal development. For the instrumental part of the life domains, we have health, work, financial situation, and active recreation included. For intimacy, we talk about the relationship with partner and the sexual life with the partner. And for the third life domain, it's about the family and other social relations, including self and religious expression, community and civic involvement, and also the passive recreation. For the socio-demographic variables, we included gender, marital status, age, socio-economic status. For the methodology, we have to say that we have used descriptive analysis, correlation analysis, and also hierarchical multiple regression analysis, as you are going to see from our results. These are the descriptive characteristics of our sample of patients according to these instruments and subscales. And now let's move to the first results. Here you can see the significant differences in the cancer participants depending on their gender and the effect sizes. So we have male and female, and we have the level of medium to large effect sizes and small effect sizes. What we see from this figure is that women had scores significantly higher than men regarding the total score of fear of cancer progression, for affective reactions, and also for unhelpful, maladaptive coping mechanisms included in the fear of cancer progression questionnaire. We have seen the same situation on illness intrusiveness, including the relation component of it and the received instrumental support part of it. Also, women had scored, significantly higher on anxiety levels, albeit with small size effects here. Moving on, here we can see, based on the marital status, the significant differences in the assessed participants. We have the following categories under marital status: single, married, divorced, and widowed. And also, here we can report about medium-size effects. So, single participants had scores significantly higher than the divorced or widowed participants on the subscores of fear of cancer progression questionnaire, which is on the part related to the family relationships. Also, single participants had significantly higher scores compared to the other groups on illness intrusiveness, measured with the IIRS questionnaire, and also on the global scores of illness intrusiveness. So we had the gender and marital status and also the differences in the light of size effects. Now we can see here the differences, the significant differences in the assessed participants depending on the marital status, in which we have also the small to medium size effects and the large size effects. So we have on the relationship subscale of the IIRS scale, significant differences between single and divorced and married and widow participants. Also, on the instrumental aspects of this instrument, we see that the widowed participants are reporting significantly lower levels compared to the single, married, and divorced participants. As for the levels of depression, widowed, married, and divorced participants are indicating significantly higher scores than the single participants. And we are now moving in the large effect size category on intimacy subscale, where we can see that single and married participants have attained significantly higher levels than those who are divorced or widowed. If we are moving in all these variables in a hierarchical regression model with step 1, step 2, and step 3, we will get a model of mediation that you can see here in this figure, where we have gender, anxiety, and the relationship subscale of the illness intrusiveness. They all together, these three significant factors from the regression model, they are actually accounting for 38.2% of the variance in global fear of cancer progression questionnaire scores. So this is the part, the percentage they explain. Gender, for example, first, as a predictor of fear of cancer progression, is statistically significant, predicting 3.9% of the variance in FOCP. The IIRS relationships subscale is also statistically significant, explaining much more, actually 13% of the variance of the FOCP. And anxiety, as a predictor of FOPQ global scores, is also statistically significant, explaining 21.3% of the variance in the fear of cancer progression questionnaire scores in the global. So if we are going to take conclusions and discussions, we would like you to propose a very structured way to do this. So on our sample, a nationwide and representative sample of 330 Romanian outpatients regarding the fear of cancer progression, we have identified first gender differences. Fear of cancer progression scores are significantly higher in female than male participants. This is the first important conclusion. Effective reactions in female cancer participants are also significantly higher than in male counterparts. And regarding gender differences, female participants had significantly higher scores than male participants regarding the unhelpful, maladaptive coping mechanisms that are included in the fear of cancer progression questionnaire. On the second level, the marital status differences, the subscores of the FOPQ related to family relationships showed that single participants attained or indicated significantly higher scores than those who are divorced and widowed. As we are moving to the illness intrusiveness conclusions, on our sample of 330 Romanian outpatients, we can say that regarding to the gender differences, we have identified the following results. On the subscale of relationships, female cancer patients reported significantly higher levels of illness intrusiveness than their male counterparts. On the instrumental subscale, or the instrumental support, female participants reported significantly higher levels than males, and the same pattern we are going to see On the emotional reactions, female participants reporting significantly higher levels of anxiety than male cancer patients participants. On the marital status differences on IIRS, we start with the global scores. We have shown here that single participants presented significantly higher levels of illness intrusiveness than their married, divorced, and widowed counterparts. On the intimacy subscale, single and married participants are having significantly higher levels than divorced and widowed participants. On the instrumental support subscale, widowed participants attained significantly lower levels compared to the single, married, and divorced group of participants. And the major emotional life markers, widowed, married, and divorced participants reported higher levels of depression than the single cancer patient participants. So these very important results will have to be discussed from a theoretical and practical implications perspective as well. So first, we had a multi-level approach of analyzing the relationship between fear of cancer progression and the illness intrusiveness, taking into account the dynamic relationship between them and also the extent to which their interaction differs from one level to another, and also the mediating effects. We certainly know that cancer is a comprehensive experience and very much personalized, but it is impacted by both socio-demographic variables such as gender and marital status, as we have seen from our significant results, as well as psychological variables, factors such as anxiety and fear of cancer progression or recurrence. The current study from the CANPRIM research project identified anxiety as the most important predictor of fear of cancer progression during pandemic in the Romanian cancer patients, explaining again 21.3 of the variance in the fear of cancer progression questionnaire score, which is 5 times higher or more than for gender, and almost 2 times more than interpersonal relationships. So we know from the psycho-oncology clinical practice and of course from the literature that we can modify and we can intervene in a very effective way on the anxiety experienced or felt by the cancer patients, and the level of its intrusiveness in everyday life can be changed. So we need practical changes, which means that in this study we have identified the need for personalized intervention based on gender, marital status, and patient needs, interventions that can support skills development necessary for the optimal fear of cancer and fear of cancer recurrence and fear of cancer progression management on a personal level. Before we end, I would like to acknowledge that this work was supported by a grant of the Ministry of Research, Innovation and Digitization, by the UFCDI granting body. Thank you very much, and we are very much looking forward to collaborate and to discuss with you. Thank you. Thank you very much for your kind attention, and you will find our contact information on our website, that is canprim.psychooncology.ro. Wishing you all the best.